For more on this, we're now delighted to be joined over the telephone by Dr. Islam Anan, the Professor of Pharma Economy and Epidemiology. Dr. Islam, good afternoon to you, sir.
Good afternoon, Masanji. Pleasure to be with you on Nile.
It's a pleasure to have you with us. And of course, Dr. Islam, quite an escalating situation. What do you see the significance of the World Health Organization declaring this latest Ebola outbreak in the DRC and Uganda as a public health emergency of international concern?
So if we are talking about why the WHO or the World Health Organization declared the global emergency, it's because we are now facing a strain from Ebola, which currently got no approved vaccine for this strain. And as well, there is no strain-specific treatment for it. And third one is cases are spreading across borders. We can see now after Congo that we do have cases in Uganda.
Uganda, yes.
And as well, yes, the outbreak is happening in areas which is affected by conflicts. There's population movement, and there's weak surveillance infrastructure. However, it's very important to emphasize that this is not a pandemic. The extraordinary international health threat is just because of the above reasons, but still it's under control. We've been faced with Ebola strains from the 70s, but unfortunately we are faced now with a new strain. As you know, the first strain, which is caused the 206 and 213 epidemic was from Ebola Zaire. But currently the new strain, which is we are facing, it's a new one, and we don't have any anticipation of that rare strain to be spreading like we are faced with the Ebola strain, which is currently under surveillance, and we have a lot of mortality, unfortunately, from that.
Right. So now, Dr. Islam, if I understand this correctly, the Bundibugyo strain, which is the strain, the new strain. Yes. Now, this, of course, is obviously a new strain, which is different from the previous strains of the specific disease. What are the challenges now with regards to diagnostic testing, treatment, the study of this new strain in order to reach some sort of vaccination?
Okay, so we do have a vaccine, but it's for the Zaire strain. For Bundibugyo, we don't have any vaccine, unfortunately.
Yes.
And we do have, by the way, two other strains. We do have the Sudan Ebola virus, and we have the Thai forest Ebola virus as well. Currently, the one we are having, which is Ervebo, the Ervebo is the vaccine for Zaire, is not approved for Bundibugyo strain. We do have experimental vaccine research ongoing currently for the Bundibugyo. It's involving Moderna, involving the University of Oxford. However, we're still in phase 2. It means we need maybe 3 to 4 years to see a vaccine on ground. If they were not going to fasten the vaccine process like we've witnessed in COVID. And I really hope we don't fasten the process of the vaccine, let them take their time, and we are sure of the safety, efficacy of the vaccine. However, it raises a big concern why so far we don't have any good research and development for Ebola, unlike the other viruses spreading. It's been killing a lot of African natives in Uganda, in Congo, since the 70s, and we have a very weak research and development, despite all the efforts from Gavi, which is the Vaccine Alliance for the WHO, even CP, the UNICEF. They are trying to close the gap, but funding for Ebola still very limited and very neglected, especially for Ebola, for HIV, and the bigger concern now is that some infectious diseases, when you leave neglected like that, at a certain point of time, it can evolve. We can have a new strain like the Bundibugyo, which is very rare and now spreading. and it can face the whole world if we have travelers moving from Africa to other continents, but it will be too late to contain it. We know, of course, that Ebola is not spreading like COVID, for example. It's not going to be a global pandemic. However, we are talking about a very high mortality rate. Sometimes in some waves, we reach 60% case fatality rate, which is very high. If we compare it to COVID, if you remember, it was 1% fatality rate. So it's a very fatal virus, unfortunately.
Indeed. Dr. Islam, now with the current assessment of the risk of global transmission, as you said, we're not there, but what containment measures are being prioritized specifically? As you said, the disease has crossed across borders. So what are some of the immediate priorities? What is being done to cater, for example, for frontline workers, medical professionals on the ground, specifically in the affected areas?
So first of all is to focus on the high stress groups. We are talking about, as you mentioned, healthcare workers.
Yes.
And we have mortalities, unfortunately, among healthcare workers, elderly individuals, children, especially below 5 years, pregnant women, immunocompromised patients, people with chronic diseases, uncontrolled chronic diseases, and patients who arrive late to medical care. And the latest patient profile who arrive late to medical care is the leading cause of death. So the second measure is to have an immediate action towards field hospitals and early detection of cases, because if you can detect the case early and it's going to the hospital, you can avoid the death or the complications or reaching the third stage. Just to talk very briefly about the symptoms, for Ebola we have 3 stages of illness.
Okay.
The first one is the fever, the fatigue, the muscle pain and headache, which is okay. Any patient can be early detected among the first phase. It's very easy to survive. However, if deterioration happens to the second stage, it involves vomiting, diarrhea, the pain, and internal bleeding. And this is a very serious symptom because it will deteriorate to the third stage, which is the hemorrhage stage. Severe hemorrhage, multi-organ failure, shock, and unfortunately, a potential death within 2 weeks. So having field hospital will make us avoid that. And fourth measure, which is border control, to make sure that no one is leaving the Republic of Congo unless it is actually examined at the airports or ports. And all the neighboring countries, we're talking a country like Uganda, are taking the same measures upon arrival of any passenger from the Republic of Congo. Another thing that should be done and currently ongoing from the WHO is to have a health education and awareness among healthcare workers, how to avoid infection, and among the population, how to make sure they are not infected. We're not talking about respiratory infection, so it's easily contained if the general public got the necessary awareness about how to avoid the dealing with infected cases or dealing with other animal hosts, like, for example, the bat, because it's actually transmitted originally before the human-to-human interaction from bats.
Right. Now, Doctor, let's talk a bit about how, for example, the history of the outbreak of such a disease in the region of the Democratic Republic of Congo, for example. Has this given them some sort of edge or expertise with regards to managing the events evolving around the spread of this virus? How are they ensuring, for example, safety or safe burial, for example, practices, specifically given, you know, the sensitivities, cultural sensitivities, and the high risk of transmission after death as well?
So, as exactly said in your introduction, Ebola was first discovered in 1976. It's not a new virus. And it was named Ebola after Ebola River in Zaire, which is currently Congo.
Yes.
However, the strain we witnessed back then was Zaire strain. From that time, Africa witnessed multiple outbreaks, but the virus remained geographically limited in Congo, mainly because, as we mentioned, the transmission requires direct contact with infected bodily fluids, unlike any respiratory virus. And after that, as we mentioned, in 2013, we had the biggest outbreak. we're talking about 27,000 cases and around 18,000 deaths. So the WHO, the Congo, they made a lot of efforts to have a vaccine. They made a lot of efforts to have hospitals designated and specialized in treating Ebola. Still, we have a high fatality rate after that. It was 50 to 60% in the 70s. After that, in 2010 and 2020, we reached an average of 30 to 35% fatality, so we can see an improvement.
Yes.
However, we were not anticipating at all that a very rare strain, like the one we are facing currently, to be the one making the outbreak. And the biggest fear among all the international organizations, if the current strain will spread like 2013 to involve thousands of people, reaching 10 to 20,000. And we hope this will never happen.
Absolutely right. We'll have to leave it at that. We have run out of time. Dr. Islam Anan, Professor of Pharma Economy and Health Policy Consultant, many thanks, sir, for your time and your insight and for joining us this afternoon. And that wraps up today's edition of Africa Today. You're in the company of myself, Angie Meher. Thank you for watching.